Today's topic again is cognitive behavioral therapy, or CBT, specifically for relapse prevention. And our objectives today are to provide a brief overview of cognitive behavioral therapy, CBT, the components and the interventions specifically related to relapse prevention. We're going to describe classical conditioning as it relates to substance use, and we're going to discuss the role of high-risk situation planning in relapse prevention. As usual, we're going to have a lot of information to go over, and I want to leave plenty of room for the case. So if you do have any questions or points where you'd like me to expand, please be sure to put them in the chat so that I can return to them at the end of the presentation. We're gonna go big picture. All right, so we'll start out with the stages of change diagram. This is probably familiar to many of you who have been watching these presentations for a while. This describes the different cycles that people can go through during their journey of substance abuse and recovery. And the point that we want to make here is that relapse prevention skills have a really specific spot that they fit into this cycle. And that's between action, where people are taking positive steps to put their plans into action for healthier behaviors, and the stage called maintenance, which is where those new behaviors become the norm. They're no longer things that are having to be consciously practiced per se. It's just the way life is. So relapse prevention skills fit really nicely in there. They don't work so well earlier when people are just contemplating whether or not they want to change. But once people have started to make progress and they want to protect that progress and really instantiate it, that's the perfect spot for relapse prevention skills. So we'll start out with a sort of overview of cognitive behavioral therapy, CBT, as it relates to relapse prevention. Generally, CBT is a therapy that addresses the links between thoughts, feelings, and behaviors. It has numerous very well done studies that provide evidence for how effective it is for treating substance use disorders, a variety of substance use disorders alongside dual diagnoses as well. Some of the advantages of CBT are that it's very flexible. It can be implemented in many settings. It is short term and it's highly focused, and it works in combination with medication, of course. And one of the points I want to make today is that while it's always preferable that a patient would receive the full protocol, if there are barriers to implementing the full protocol, either circumstantially or in terms of the patient's willingness, a great thing about CBT is that it's very modular. So if you need to, you can pick out interventions and supply them to the patient as they're able to receive them. So we'll go over some of those interventions in particular that are great and modular. So looking at this concept map of cognitive behavioral therapy, you'll see in the inner circle, there's thoughts, behaviors, feelings, and physiological sensations. And you see that all the arrows there are bidirectional. They all affect each other. With CBT, we try to act directly on cognitions and behaviors because those are the easiest points of entry. It's much more difficult, if at all possible, to act directly on emotions and less so physiology. You'll see that there's the arrow coming from the outside, from the environment. So these are sometimes triggers come from the outside, but sometimes it's important to remember they can come from the inside. An example would be a memory that comes up and acts as a trigger, and it kickstarts this cycle. I'll give a really quick example about how these arrows work with each other. If you imagine that you're in traffic and somebody cuts you off very rudely, maybe you have a thought of, who does this person think they are? You know, they don't respect me. What are they doing? This leads to emotions that might be anger, resentment, frustration. This could lead to physiological sensations like increased heart rate, perhaps muscles clenching, sweating, or flushing. And this could lead to behaviors that are not so helpful for you or other people, like trying to retaliate, cut them off, or maybe in the context of this presentation, taking the next off ramp and saying to yourself, this is the last straw on a bad day and I deserve a drink. So you can see how all these arrows kind of act with each other. And then if you can intervene at that top point of the cognition, so if you're able to, for example, supply an alternative story or an alternative thought, such as maybe this guy has a child that he's trying to rush to the hospital. I hope he gets there quickly. This allows a sort of different pathway with those arrows. Perhaps then you're starting to feel like you're on this guy's side, right? And you're not experiencing quite so much of the negative emotions. Interestingly, with CBT, you don't have to actually believe that alternative story. It's really mostly about getting distance from that initial automatic thought and thereby being able to intervene at different spots throughout these arrows. So we'll look a little more closely at what this means. Let's look at session structure first for CBT. They are typically hour-long sessions divided into 20-minute subsessions. It's very structured with a full protocol. The clinician is providing a very active stance. And one of the tough things about it is you really have to balance this position of being empathic and responsive to the patient with delivering quite a lot of information in a short amount of time and making sure that it's well integrated. So that's about balancing that kind of very directive stance without being robotic or impersonal about delivering the information. In the second part, or in the first part, you're going to set an agenda for the session very literally. You'll say, today we're going to discuss dot, dot, dot. You're going to briefly discuss the patient's current concerns. This is not an approach where you're really delving into childhood or other kind of further flung items. You're really focusing on the present for the most part. You're going to obtain a detailed day-by-day description of their substance use or their cravings and urges since the last session. And very importantly, you're going to review and assess their practice, their homework from the previous week. I'll repeat this a lot, but the homework is where the change takes place in CBT. You want the patient to know that, you want to appreciate that as a provider, and throughout every session, you're really going to hammer home how important the practice is. In the second part, you're going to introduce whatever the new intervention for that day is or the topic. You're going to do your best to interpolate it with their current concerns so that it doesn't feel quite so impersonal. You're going to try to weave it in with what's going on with them and what their goals are. And with CBT, even more than most other approaches, it's really, really important that you are ensuring comprehension on the patient's part. You want to make sure you're calibrating your language to the education and the literacy level of the patient, and that you're constantly checking in to making sure that they have heard what you have said the way you expect them to. It's just so much information. It's a lot for them to integrate. You want to make it as accessible as possible. Part of how you do that during that second part of the session is practicing the skills in session. So that's a good comprehension check in itself. Then in the third set, again, more comprehension check. You're really exploring, how do they understand this? What is their reaction to it? How does it fit with their understanding of how they're going to make progress? You're assigning the practice exercise for the next week in the context of, this is how you're going to make progress. This is how you're going to, how you're going to help yourself. And you're going to review the plan for the period ahead to identify potential high-risk situations. We'll talk more about that in a bit. And you're going to use a schedule to create a behavioral plan for the time between sessions in order to reduce the likelihood that they're going to run into high-risk situations. So some of the general challenges for CBT clinicians include that it can be really difficult to stay on topic. Patients who are used to more open-ended forms of therapy are really going to want to come in and take the reins and digress, and it can be difficult to diplomatically redirect them. Similarly, as a provider, if you're used to a more open-ended form of therapy, it can be really difficult not to let that happen and to shift into a slightly more passive stance. So again, managing the session in a flexible manner so that you're not being robotic and the patient really understands that you are on their side and treating them as an individual. A very common feature of CBT on the provider side is you're going to need to problem solve why homework hasn't been done. And it really is important to inquire about why that's happening, because there can be so many reasons, and virtually all of them can be helpful indicators for treatment. It can be that a patient doesn't have the confidence to execute the homework. It can be that they don't fully understand why this is going to help them. They may not have faith in treatment. There are so many reasons, including just logistically, they don't have the time at that point. So you really want to make sure to identify what the problem is and to troubleshoot it with them. You're always emphasizing to patients, the driver of change with CBT is what they do outside of session. So it's really important that they're doing it and doing it in a way that's going to help them. So let's look at some general considerations in cognitive behavioral therapy for relapse prevention, starting with the importance of repetition. And this really can't be overstated. It's important to remember that working with this population, usually by the time they've gotten to treatment, they've spent a lot of time and effort and thought into getting and using substances. And it's going to take a lot of time and effort and thought into unwinding those habits and replacing them with new, more adaptive ones. It's going to take a lot of practice. It's also important to remember that chronic substance use is likely to affect people's cognitive abilities, particularly their memory. So there's a very concrete reason to make sure you get the repetition in there, particularly with key principles. And something you want to communicate directly to the patient is that it is not a sign of failure when you need to repeat perhaps even whole sessions and certainly parts of sessions. It doesn't mean that treatment isn't working for them or that they're not doing enough in treatment. That is a very common way that it goes with CBT for relapse prevention. It's helpful to remember that with this population in particular, when it doesn't live up to the patient's expectations of the progress they should be making, they're very likely to blame themselves and lose morale, and you don't want that to happen. So this is an important part of the psychoeducation, that repetition is key. Similarly, as I mentioned before, providing a rationale for the type of intervention that you're supplying and how they're executing it is absolutely critical. You do not want to send them off to do something that's going to be difficult and challenging and probably annoying for them without understanding how it contributes to their goals, how it's going to address their presenting problem. So you constantly want to reiterate what they do outside of practice. That's what's going to create the change that they want, and that you're on their side and making sure that they're getting the skills that they need and applying the skills in a way that's going to help them. Monitoring is an indispensable part of any type of CBT. You really want to make sure that you're understanding how they're practicing. So it's not just that they are practicing, but you understand what that looks like in real life, because you'll find some patients find very creative ways to apply the practice. And you really want to make sure that it's going to fit with their goals and help them to learn new skills. Again, you want to make sure that you're processing any kind of difficulties that they have with it, whether it's logistical or emotional, and letting them know that you're on their side and that they're not troubleshooting it alone. You're going to help them find out how to make this work. So successive approximations, this is a phrase that some of you might not be familiar with. That refers to incremental pieces of a behavior that accumulate towards a larger behavior. A simple example would be if the larger behavior is driving a car, then a successive approximation of that behavior is to open the door and get into the car, right? You can't do the whole thing without doing that little piece first. So you're praising any little small piece of a behavior that sort of points towards the trajectory of recovery. And you really get good at looking for what's the smallest sort of unit of change that they made that I can praise and highlight and reinforce them for. So it could be that they didn't do any of the homework, maybe there were regressions on other fronts, but they showed up to therapy, and you're going to praise that up and down. You're going to say, I know it takes a lot, and this is a huge part of you getting better. This is great that you showed up in treatment. It really shows your commitment. So that, I think, is a fun part of CBT, is kind of almost being a cheerleader and really looking out for those opportunities to reinforce every little change that they're making, because it's very difficult, and generally they do need that morale boost. It's helpful to think, I think, of therapy in general in the same way that we think of recovery from substance use overall, which is it's going to take a long time. Relapse is part of the process, and you want to communicate that in terms of setting their expectations for treatment, because again, if treatment doesn't live up to their expectations, or they feel like they're not making enough progress, they're often going to blame themselves and drop out. If you can make sure they understand how all of these incremental changes are leading towards the big change they're looking for, they're much more likely to feel hopeful and stay in treatment for the length of time they need to complete the episode of care. So we'll look more specifically at triggers now, and that's about understanding the external and internal triggers for urges to use, which are thoughts that lead to the use behaviors. So when we think about how the initial trigger eventually leads to the use behavior, there are many points in the links of these chains between the trigger and the actual use, and you can intervene at any point. The further upstream you intervene, the easier and the lower risk it is for the patient. So the ideal situation is that they just never have to encounter a trigger. That certainly is the lowest risk and the safest course. But a person's life becomes very small if they're avoiding triggers entirely, and you certainly don't want that for them either. So once a trigger has occurred, there's the point of intervention between the trigger and the thoughts about using that you can modify with cognitive restructuring, then between the thought and the craving itself, and then we'll look particularly closely at once it turns into an urge, what they can do to stop in that final phase before it becomes a behavior. We'll start out by looking at how triggers are formed, which is to say how associations between using substances and the circumstances and the items in the environment become paired with that craving. So probably many of you have heard of classical conditioning or Pavlovian conditioning. This is that famous experiment from early 1900s where Pavlov discovered that you could pair an unconditioned stimulus, such as food, with an unconditioned response, such as a dog salivating in response to food. So those are unconditioned because that'll just happen no matter what. You don't need to train a dog to do that. It just happens. And he discovered that you can pair a neutral stimulus, such as a whistle, with that food, and that over time, the dog is going to salivate in response to the whistle. So the whistle, in a sense, has become so entangled with the food that the dog's response is the same for the whistle as it is for the food. This sounds really basic, but this actually became really the foundation of behavioral therapy in the 20th century. And when you think about it as we apply it to substance use disorders, and you consider that substance use is about the most reinforcing unconditioned stimulus that a person can experience. It acts so powerfully and immediately on the brain that it's very sticky in terms of association. So any kind of neutral stimulus that's in that immediate environment or even that chronologically precedes the use, that's going to get stuck in that web of association with the use itself. And that's really hard. So it's not just about identifying all of the triggers and using that as part of the behavioral plan. It's also about having empathy for people who are in this situation where they're walking around the world and people and places and things that might seem innocuous or innocent or positive to the rest of us, those are like landmines for them. And it's going to bring up really difficult feelings, and it makes the world really feel like a scary and a dangerous place. So I think this is an important piece for empathy for providers, as well as understanding that behavioral chain. So how do we address that? The foundational intervention is to use a functional analysis, which is a diagram of the people, places, and things for patients to identify what their biggest triggers in high-risk situations are, so that they can learn to manage them in advance to the extent that's possible. You're also examining and exploring alongside them the long and the short-term positive and negative consequences of substance use, because you're really wanting to make sure that they are clear to themselves on why they're willing to make this change when it's so difficult. And you're looking at how to develop positive reinforcements, which is also called behavioral contingencies, and meaningful alternatives to substance use when the trigger is present, because you don't want somebody to go from something to nothing, so to speak, in terms of responding to a trigger. You do want them to have an alternative to turn to in that situation. So this is what a basic functional analysis diagram looks like. You'll see we have external and internal triggers, the behaviors, and then the short-term positive consequences and the long-term negative consequences. And this gets filled out throughout treatment. You start out by really focusing on the triggers, and then once those are very clear to the patients, you start to develop more and more the other columns. Something that you'll notice that's really interesting and very telling about filling this out with loved ones of patients is that they cannot comprehend the short-term positive consequences, which are very clear to the patient. Usually patients know exactly why and what they're getting out of using, but they don't really see the long-term negative consequences at first, and it's very much the opposite for loved ones. So that's part of kind of integrating those perspectives. So looking at behavioral contingencies, which is the positive rewards and the alternatives to use, it's helpful to remember that in terms of consequences, and in this particular context, consequence can be positive or negative. Both can change behavior, but we do know from current research that positive consequences are more effective in the context of behavioral treatment because they increase desired behaviors and they teach new skills, whereas negative consequences just decrease undesired behaviors without teaching new skills to replace them. Also, we find that punishment really only works while it's visible and around, whereas positive consequences kind of help people learn those skills that are then self-reinforcing so that you don't have to keep applying the reward over time. So the main thing to remember here is that, very contrary to the way that substance use has historically been treated and the way that a lot of society looks at it, we do not want to punish people into trying to change their substance use. And that goes for patients themselves. Often they're trying to punish themselves into abstinence. And that is not a very effective approach compared to rewarding themselves for changing their behaviors in positive ways. So how do we do that? In terms of applying behavioral contingencies, we'll have a presentation at the end of February that looks very specifically at contingency management. This is just a very abbreviated sort of summary. But you're looking at identifying behavioral targets. The most common would be attendance at treatment or abstinence as verified by a negative urine drug screen. And you're going to reward that with something tangible and immediate. With contingency management, that would be vouchers or prizes. At a lot of the clinics, you're going to get privileges like take-home doses, if you can show that you're following treatment. In 12-step programs, an equivalent would be a sobriety chip or public acknowledgement. And something I'll mention here, because it is important, is that you really want to make sure that whatever the reinforcement is, that you have verified that it is relevant and salient to the patient, because it's not always what you think it would be that's helpful to them as a reinforcement. So this is an alternatives to use table. This is about helping people reorient to different ways of managing difficult emotions that in the past they've been using substance use to manage. So if you can identify, okay, so it's primarily relaxation that you're looking for when you've used this substance in the past, What are some other things that help you to feel relaxed, that you feel better about, that are better for you and your family, that are more sustainable long term? And a distinction I do want to make here is you never want to give the impression this activity is going to make you feel exactly the same way that the substance use did, because it's not. There's just no way that you can compete with how powerfully reinforcing substances are. But what you can help the person to do is over time build up a wide and flexible repertoire of alternatives that are pleasing to them, that are satisfying, and that provide the meaning and sustainability that they're looking for in taking this new path in life. So it could be, joining a gym. It could be going out to a movie with friends who support your abstinence. It could be ordering takeout at home. You're going through it on an individual basis and identifying what's going to be most motivating for this person that's going to help them to, in this case, relax. So we'll look now quickly at urge management. How do we identify and modify urges before they turn into use? This is the most basic version of a record of urges. And it's just date, the situation, which includes thoughts and feelings, the intensity of cravings, and the coping behaviors. When you start out, that last column is going to be really sparse. That's a great indication of where you can fill in some skills for this patient. A somewhat more complex model, and I'd say this is the better one because it helps people to articulate the links between the triggers and the urges. So you're looking at, did you use, how much did you use, categorize the urges, what are the situations, and then separately, what are the thoughts and feelings. And this is a really important foundation for all of the more complicated or the more advanced interventions for urge management, is the patient understanding what are the things that make them vulnerable and how do those things coalesce from trigger to the actual behavior of use. So I'll give you a really brief abbreviated sample of one of those urge management interventions. And this comes from mindfulness-based relapse prevention, which is one of several types of CBT for relapse prevention. And this is looking at urges like they're ocean waves. And the natural inclination of a lot of people is to say, okay, I have to resist this urge and to sort of square off with the wave and try to just hold your ground as it crashes over you. And if you've spent much time in the ocean, you know you're going to lose that battle. Whereas if you learn how to surf over the top of them and just go with the wave, eventually you might even have a little bit of fun with it, but it's certainly going to be more successful than trying to fight the wave. So with urge surfing, you're going to notice the urge, watch them rise and fall. You're not going to respond to the urge. A really important part of this intervention is helping people understand that physiologically, urges cannot last much longer than 20 or 30 minutes tops. So if they're able to just distract themselves or get themselves out of the situation for that much time as they're urge surfing, that's going to allow the urge to pass, and then they're able to move on with their lives. It's also important to remember that the more they practice this, the better they get at managing the urges and the smaller the urges get, because every time you give into the urge, it gets larger, like a wave that's getting bigger and harder to ride. So the foundation there is the urge management charting, learning to identify and label the urges, and then you build interventions like this on top of this so that patients have a specific skill they can use to respond when those urges arrive. So lastly, we'll wrap up with high-risk situation planning. The idea here is just that, like, the same way that you're gonna practice for a fire drill, even if you don't expect a fire to happen, you wanna make sure you know where the exits are and what you're gonna do in that situation. And with relapse prevention specifically, you wanna make sure that you know what the contexts are that are gonna make you vulnerable to relapse. So it's not usually just a single trigger. With a high-risk situation, it's about multiple embedded or contextual triggers. So that could be something like a party, or it could be something like this is the time of day when a person typically used, maybe when they come home from work and they're feeling stressed and they're in this environment, right? It's multiple kind of points in confluence. So this is going to sound very basic, but this is really the golden ticket of relapse prevention. If you can teach patients to spend less time in high-risk situations, which have been associated with substance use, and more time in low-risk situations that have no association with substance use, that is very likely to keep them in recovery. Again, it sounds so simple. It's almost hard to explain this without sounding insulting to patients, but over time, they really start to see the utility and realize, hey, this is really intervening at the top level. I can save myself a lot of time and effort if I just avoid these people, places, and things that make it very difficult for me. So at the end of every session, what you're going to do is fill out this basic high-risk situation planning worksheet, which is what are the situations coming up that you anticipate are going to be difficult for you? How are you going to handle them concretely? This isn't just, oh, I'll take care of myself. This is, who's going to be your support person? What's going to be your excuse to leave? That sort of thing. And then you make sure that they carry this with them. So they're either carrying a hard copy in their pocket or they take a picture with their smartphone, whatever it is, you want to make sure that they're not going to have to improvise when the situation comes up, that they've thought through it, that they have a strategy. And tying into that, you're making a plan at the end of every session to make sure they know how they're going to spend their time before the next session. This is not just a skill that many people in this population are missing. It also really makes them vulnerable to relapse because that kind of idle time is often when the urges to use are most difficult to overcome. So really scheduling even down to the hour can help them avoid the pitfalls of being drawn back into old habits. And when they can do that in advance with you in a low stakes situation, they're going to come up with much better ideas than if they have to think of it on the spot in general. And you do, of course, because this is kind of an annoying thing for patients to have to do, want to provide the rationale that if they follow the schedule, they're much more likely to be able to avoid triggers and therefore avoid using.